Um, Welcome everybody to the first episode of the Random Anesthesia Topic podcast. We have Dr. Natasha Bertel. She's Chief Medical Officer at King Animal Hospital in King City, Ontario. And then we have Dr. Ryan Bailey, which is the anesthesiologist at the Premier Veterinary Group in Chicago. Awesome. I'm the anesthesiologist here at Oklahoma State, and I also own a consulting company called Safe Path Anesthesia. I'm probably the southernmost of the three of us. Um, Actually, here is super warm, super hot this week, so
Oh
it's
no, it's like
crazy.
90 degrees up here. Like, don't let Canada fool you.
90 degrees
This,
Celsius?
No, obviously I'd be dead. I was translating into Fahrenheit for the benefit of you two.
I do Celsius. I've been doing
I was
Celsius my
just trying
whole
to relate to
life.
the American audience, but if you want to, it was 38 degrees Celsius, which is
There you go.
What's hot?
You know what I have to do? I have my phone in Fahrenheit and my Apple Watch in Celsius, so that when I call my dad in the morning or my mom, I can actually tell them the temperature.
yeah, America,
So,
like you guys need to just get on the metric ship. Like just stop being so difficult. I'm over it. And I'm tired of having to convert like blood values and like all that kind of like blood glucose. Like, no, no.
Yeah, it's really annoying. It's like genuinely the worst. I will also say I have made that Celsius joke like more times than like I think it's so funny. It's like one of my favorite jokes.
Um, I mean, it is funny, which I think says a lot about anesthesiologists in general.
100%.
For the record, it's
100%.
115 with the heat index here today.
Oh
Top.
God. Yeah. Even in
Holy cow.
Celsius, that's sweaty. Like, woo.
I didn't think that Chicago was getting that hot.
Yeah, it's really
That's
hot. It's all
crazy.
the corn sweat, apparently, just in case you were wondering. There's a lot of
Excuse
corn
me?
sweat information going out there. Corn, when it like matures or something, it produces humidity. And so we're in like a really corn sweat heavy situation. So the humidity is thick.
Are these
Wow.
actual words that just came from your mouth? Like
Yeah.
corn sweat?
Yeah, you can look it up.
No, I believe you. That's the sad
Yeah.
part.
Yeah. It's worse than champagne, for the record.
Oh,
Wow.
Yeah.
okay.
That's nuts.
I just
Yeah.
thought Chicago was toasty because it's like a concrete jungle, but I didn't realize you had to factor in this whole sweat of the corn situation.
That's
Well,
nuts. I knew that New York was
you every day.
crazy hot. And New York is crazy hot because of the AC, apparently, right? So all the massive buildings have these ginormous AC systems, and they actually make the outside temperature 1 Celsius degree hotter than it should be just because of all the ACs.
What are you
So
guys doing
it's
in your free time? Like researching like thermoclines? Like what is going on here? Like why do you know this about like a New York air conditioning and corn sweating? Like I don't know any of this. And P.S. I don't care.
You've got better
I
things
guess
to do, apparently.
exactly. You traveled so much that
Yeah, I'm on a
you
break.
don't
I'm
get time.
exhausted. Yeah, it's time to just hang out with the cat at home. Like I'm on my traveling break. I've you know what? I've contributed to global warming through my carbon footprint, and now I'm playing it down. So don't nod, Bailey. Don't nod. I'm not
That's
the place
awesome.
that has corn sweat issues. Okay, so don't even try it.
That's awesome. So I guess the question I have for you guys is anesthesia related, just
The
to go.
surprise question. I just want everyone on the podcast to know that we have not been briefed, so this is like a surprise exam for us.
Yeah. So every episode we're gonna pick a random question, and actually it's truly random. So I have actually three envelopes, and I just picked one right before we
Oh,
started. Um,
wow. It's so
It's
that was
official.
like
it's like Cards for Humanity, but not funny and maybe not fun. And totally like
probably not.
related. Yeah. Ooh,
In
okay.
some way, it
Oh,
feels like doing oral boards, but like both more and less intimidating because it's being recorded. At least no one was recording me make an ass of myself in oral boards, so that was good.
I'm glad I'm not the only one who walked out of that feeling really stupid.
I guess the question I had for you today is, so, a lot of practitioners out there, the very first thing they do as soon as they see some hypotensive patient is to give a fluid bolus.
Let's just rip that can of worms right open from the first question. Like, yeah.
Right. Yeah. I know
Good.
it's loaded. It's loaded, right? But what's your thought on that? Like,
So this is
I'm gonna let Bailey rock on this
let
one
me
first.
jump in real fast on and like totally derail the conversation before we even start. But I was reading, there's an anesthesiology humans focused subreddit that I have discovered, and it is like truly brings me such joy so often. But today's topic, there was a discussion topic on the use of fluid therapy in septic patients and bolusing versus like prosthesis. And obviously it's this very specific subset of patients. So like not applying to this patient that we're discussing here, but just so much of their conversation is focused on not just the like subjective slash objective measurements that we do have access to in a non-invasive way, but so much more focused on invasive and like semi-invasive measurements like TEE and like Doppler measurements through like an esophageal probe placement type device that like we aren't even using in academics routinely, and also discussing like using targeted variables like like central venous pressure and other other markers that we're not routinely monitoring in our veterinary patients because of complications, and just like we're basically decades behind and like just being really sad. Sorry to bring it down, everyone.
Yeah, anyway, that was a great
sad
podcast.
truth.
Thanks, Bailey.
Sad truth. But
Yeah,
Yeah.
that's,
great.
I always tell my students, they were like 25 years behind at least.
Oh my God. Yeah.
Where'd you get that random number of 24?
I
Was it from the
it's a
corn
random
sweat?
number.
Like, what's happening?
Yeah.
It's the corn sweat, yes.
Is it Celsius? But yeah, no, do you start with a fluid bolus? You know what? We should just call, we should call this podcast It Depends. That should be because I swear to God, that's going to be my answer like 98% of the time. Like it's such a rare occasion where I have like absolute like black and white cutoffs for things. And I know that's never particularly helpful for people who are uncomfortable with anesthesia or who's still on a growth trajectory for their own learning and skill. But that's like my official answer, right? Like if, the first question out of the gate is, am I giving a fluid bolus because that patient is hypovolemic? Right? And the next question I ask myself is, do I believe in relative hypovolemia from a state of induced vasodilation? And just because you have a volume deficit does not make you a fluid responder. So I actually don't think there is a right or a wrong answer here because I don't think anybody knows what the answer is. It's the same thing. It's not just fluid, it's the type of fluid, it's the rate that you give it, it's the total volume per like body kilo that's actually given, it's the physiological state of the patient. So what's renal function, what's cardiac function, what's vascular status like, it's so highly subjective, both from the point of view of the clinician and from the point of view of the patient. And at some point I feel like for me fluids almost has reached the point where it's like an art form. Like I almost go on like this gut intuition of like how much volume I think the patient needs. And yeah, I'm looking at pressures and rates and pulse pressure variations on ventilation and lactate and, et cetera, et cetera. What's my base excess? But, I get a good feeling like after one or two boluses, like if I'm looking at those parameters, you're not really improving, I'm going to switch tactics pretty fast. Like I'm going to change tack because I'd rather not volume overload you, and not volume overload in the sense of like everyone thinks volume overload equals pulmonary edema. But for me, I'm thinking more like gut edema, and I'm thinking more hemodilution, which is going to send the criticalist just off the fucking rope. But like dropping calcium and like I mean, all those kinds of things that you get as punishment for being aggressive with fluids. So yeah, my answer is it depends. Do I think it's right or wrong? No. I think starting with a fluid bolus is reasonable in most instances, and especially in GP where they don't have phenylephrine or noradrenaline to hand. But yeah, that's my 2 cents. That's my 2 cents of veterinary anesthesia. Maybe
I
we should
mean, I
call
think
it 2 cents.
yeah,
Or 3 cents, as the case may be.
I I feel like when you're dealing with these like, you know, looking at patient population, like these 95% patients that we're talking about, I don't think if like matters what you do. Like you could do anything and it's probably going to be fine. Like I know it's like a terrible answer, but like in these patients who are otherwise healthy, who have very low level of comorbidities, also because we're dealing with dogs and cats and not like smokers and drinkers, like we are so fortunate that like we can almost do whatever we want within reason, and because of standard deviations and bell curves, it's going to be fine. And that's like a terrible,
Yeah.
very sad
I mean,
answer.
No,
most of the GP animal population is not going to hit the table in a state of hypovolemia.
Right.
Right? Like that's usually like referral level stuff, like you have
Yep.
patients who are in hemorrhagic, septic, cardiogenic, neurogenic shock, and you're just like, "Ugh, blah, blah." But like a routine spay who has no hemorrhage on the table, like what are you bolusing that patient for?
Yeah.
What is that achieving? Right. And then you think about their total anesthesia time is like 15 to 20 minutes. So the total volume of fluids you probably given is like 14 mils total, not even per kg. Do we honestly think that 14 mils total has made some sort of beneficial difference? I'm
So that
struggling.
brings up something that came up in symposium last year. Lydia Love talked about it, but thinking about fluids as more of a total dose over time and not as like a mils per kilo per hour essentially. And so that like that feline neuter, that, quick spay procedure in a GP, should those cases really be on 10, 20 mils per hour of fluids because they're getting so little fluid just as a function of time. And that like there are like curves in humans showing like increasing mortality with limited fluid rates, decreasing to a certain point, and then increasing back up again. And so what we're looking for is this like Goldilocks situation, which I guess that could be the name of the podcast, Goldilocks and the anesthesiologist.
Yeah,
um,
So what we're
yeah.
looking for is
Beanie,
like this.
Beanie, what do you do? Like, what are your thoughts? Like,
so here's my thoughts, right? So like I take a lot of this info from human medicine. Unfortunately, we don't really have a good chunk of literature on this in veterinary medicine. But what I always tell my students is, LRS in a healthy patient that's normally hydrated has been shown to last from injection to when it shows up in the bladder about 20 minutes versus in a dehydrated patient has been shown to last between 70 to 80 minutes, okay, from injection again to when it shows up in the bladder. So if you're not needing that fluid, it's totally pointless, right? Like you're losing it so fast that even if it was to make a difference, in reality, it's very, very much temporary, you know. The other piece of info on this, I think, is, with the new revised Frank Starling equation that puts your, with the old glycocalyx discovery and whatnot, that puts the reabsorption of fluids in the hands basically of solely of the lymphatic system. The lymphatic is so slow. Like the chance of like accumulation, it's actually crazy high now, right? And so like if the fluid gets out of the vessels really fast because you're normally hydrated and now you're just potentially slowing their absorption so much because their absorption is so slow because of the lymphatic system is the only one that now we know is the one that does that. Then, the risk of overload to me is too big. And so, like, my idea is if the patient is not dehydrated, what the hell do you give the flu bolus for? Like, it doesn't make sense, right?
Yeah, I also often hear sometimes like the patient is still hypotensive, and I'm like, okay, well, what have you done? And they're like, well, I gave a bolus. Well, how long did you give it ago? About 4 hours at induction. Well,
Right.
Sure.
like right to your point, like the intravascular retention of a crystalloid is negligible in a euvolemic or a normovolemic patient.
Yeah.
Yeah. So like I said, I think one bolus like off the cuff is probably not going to do any harm. But do I think you're going to resolve hypotension if that is your only intervention? Doubt it.
No.
Sure.
No.
But like counterpoint again, like in the like a more full heart beats stronger, right? Like you increase contractility by stretching the myocardium to a point.
Yeah, that's right. Right atrial rapid injections of fluids into right atrium will cause your heart rate to go up. Also, I
Well,
can't believe Beanie brought up Frank Starling on the first podcast. Should we be studying? Like, I was like, we started with fluids. We talked about Frank Starling. Like, I was like, we brought humans into this. And I was like, oh, this is getting technical fast. All right, people. Definitely bringing the wine next time.
what do you expect?
Well, next time one of you two pick the topic, so
God.
you figure it out.
Ooh, that is
You figure it out.
that is a danger zone. Yeah, I'm in danger. But yeah, that's I like I said, Beanie, I think it's so incredibly fluids are so subjective. And like I presented this last year at the European conference and I spoke for 50 minutes and at the end I made zero conclusions. And mine was a literature review. So I basically looked at all the relevant papers in the last 3 to 5 years, both human and veterinary. And at the end I was like, I have no answers. Take care. Like mic drop.
That's amazing.
Yeah. I'm definitely not getting invited back.
Well, but that's how it is for a lot of topics, right? We don't really have, a clear cut black and white answer. It's very much subjective, right?
Well,
So,
Bailey and I have been calling it for years fancy guessing, right? Like what we're doing is we're making skilled, educated, and experienced based decisions. But at the end of the day, I cannot write out a formulaic sheet for what you should do when and be right. So I'm fancy guessing.
I think also like in the hand, like the other, I don't know, to your question earlier, Beanie, about like for the general practitioner who has this case, like looking at it, fluids are going to be like, they're not benign, but of the options listed, they're going to be one of the most benign options that you have in, variable skill levels hands, right? Like you put the wrong patient on dopamine and it's like, boom, you've got VPCs and a cat. And like, what the hell do you do? What if that progresses to like ventricular tachycardia? Like, are you going to be pushing lidocaine to that cat? Do you have other antiarrhythmics in your practice? Like, dopamine's relatively safe, but there's definitely patients out there that are like, you don't want to meet them. You don't want the two of them to meet one another. And then the use of anticholinergics, like, I don't know. There's like, I think they're pretty benign, but they're loath to use them for some reason. So like fluids end up being this like default easy option.
Yeah, because I think they appear to be benign, but we've learned in the last 5 to 10 years that that's not necessarily the case. But I'm not sure that's being
Right.
disseminated at the level of like junior surgery and vet school, unfortunately.
Mm-hmm.
Also,
Yeah.
the humans, they make a big palava about fluids, but every time I go in for a procedure, like they basically run a liter of fluids through me in like 5 minutes so that I spend the entire procedure trying not to pee my pants. So they obviously don't care at all. They're
Maybe they just hate you.
yeah. It's really because I'm heckling them about my sedation protocol. But yeah, they're not judicious with fluids like in ER if you're presenting for migraines or what have you. Like they just slam it into you, and it's cold and it makes you wee. And, yeah, I've never
Yeah.
found them to be particularly motivated about that in any particular capacity. So,
Yeah. No, I mean, it seems like in humans they don't care for, they're very um, they have a lot of nonchalance, with a lot of things.
but they also run
I
dry anesthesia, right? Like that's an actual technique to run dry anesthesia. And like from my point
yeah,
of view too, like I don't put a neuter that I know is going to take 3 to 4 minutes. I'm not going to spike a bag of fluids. That's wasteful. And I don't think it's beneficial to the patient. And if anything, it's just going to end up floating in the Pacific Ocean on Garbage Island. So why am I incurring that cost and wasting time and polluting the environment to give? I could just push flush if I wanted to. Like, oh, this cat
Mm-hmm.
needs a bowl. I
yeah,
just push flush then,
Yeah.
right? Like, there's no point. So
yeah. No, that's fair. I
there's
mean,
no point.
the, the only damage I really see with like, people coming back to the idea of like fluids being benign, right? So fluids, I think they are benign. I mean, they could be the most benign of the options, as you say, like the least dangerous, right? More than
Yeah.
benign, I
Yeah.
think the least dangerous. But in reality, I think what makes it quote unquote dangerous from my side is that there are studies, at least in humans, that show that you know if you have hypotension for less than 60 millimeters of mercury of mean arterial pressure for 11 to 20 minutes, you double your chances of getting AKI, right? And if you go below 55 for 11 to 20 minutes, you actually almost triple your chances of getting AKI. And if it's below 55 for more than 20 minutes, it's actually, you have 3.8 times chances of getting AKI compared to a normal patient. Now, I don't know how this, I mean, I think nobody knows how this translates to our patients, right? But it's a study done in humans, of course, like 60 plus thousand humans. But, to the point is that, if you're delaying the actual real answer to that hypotension, then that's what to me becomes dangerous, right? It's not just a matter of like, oh, it's probably not going to hurt, but it does because you're wasting time on it, right? Potentially. So I don't know. I think to me, when somebody asks me about the fluid bolus, I'm like, okay, what's PCVTP, right? Like if the patient is not dehydrated, don't waste 10 minutes on it. It's total waste of time.
Yeah, and
Right.
I think
But
if those kind of numbers are being churned out for people, then I would imagine that risk is higher in cats because of their different kidney anatomy and them being desert species, and so that's concerning. But I personally, I think one of the most benign interventions you can do is turn down the isoflurane, right? Like turn down the inhalant, right? Like that's the most benign thing to do is take away the root of the evil, right? Like, I mean, almost everything then, sort of basic anesthesia is going to be dose dependent related to your inhalation agent. And the most benign thing to do is try and, turn that down, but keep them at the steady plane by using some injectable that, for example, has less cardiovascular interference. You know what I mean? So, yeah, I mean, I'm always like, okay, well, what's the depth like? I mean, cats are trickier because they'll be like crashing from hypotension and like awake. But dogs, like usually if they're hypotensive, they're usually at a deep plane. So
Mm-hmm. Mm-hmm.
that to me is usually step one is can I do something that's max sparing to take away what's actually causing the hypotension?
no, absolutely, absolutely. And to that point, I always tell my students here sometimes that like, you know, in Europe, actually, a bunch of GPs does TIVA. They just do TIVA because it's much easier. They don't have to have their vaporizer serviced every year. They don't have to worry about it. They just put everything on a propofol TIVA, and that is it.
The dream. The dream. I also another again going back to this fucking subreddit, like the amount of TIVA people are talking about doing seems like just casual TIVA cases, like just no big deal, put them on TIVA, and it's like we are so like loath to do, like we just rely so much on fucking inhalant.
We do. That's the problem. Like, I think
So
people don't
stupid.
realize this. It's so much easier. Like a syringe pump nowadays is like you can find them for $800, right? And propofol compared to the usage of propofol compared to inhalant nowadays is actually not that, like the expense is not that different. I think we're doing a really shitty job in vet schools and telling, the students that Tiva is more expensive. The reality is the way we price the anesthesia makes it more expensive. That's because usually in the packages, it does include the inhalant, right? But if you remove the inhalant out of it and you have the propofol CRI, in reality, the price will be very much comparable. But the way we priced it makes it more expensive. It's not because the propofol Tiva is more expensive, you know. It's also safer for the environment, that's the other.
I also find it wild that for the most part, we're still stuck on isoflurane. Like I don't understand. Like you'll build a brand new hospital and buy all this new equipment, and we'll still be bringing isoflurane vaporizers in, like Tech 3 ISO vaporizers. And I'm like, who? Why? Like why is this happening? I just don't understand like our married commitment to isoflurane in particular. And also, I mean, inhalants are the devil. Like, they cause almost all the problems. They make, if they leak into the room, they make everyone feel crusty. They're bad for the ozone layer. So,
No one really understands them at all. Like no one understands like anything about like the physics, the the lack of understanding of the physics of inhalant like uptake and delivery is just like fucking turn your flow to 2, crank that vaporizer to 2 and just like
Boom.
and it's like what are we doing? Like why are we not like so fine, we use ISO, whatever. Like who cares? Big whoop. But like why are there still so many places out there that don't have gas analysis? Like what are we doing?
Yeah.
Like is this the dark ages? Where's the
yes,
hammer?
yes. Just getting like expired gas analysis is like a struggle at referral hospitals still, right? Like it's because they want to understand why that is, worth the additional pricing on the multi-parameter monitor. So like that's still a fight that everyone is having, but I don't think
Yeah.
anyone understands it. I mean, to be fair, none of us technically understand the mechanism, right? And I'm like, oh, like, how does this work? And I'm like, something about a channel.
Yes.
I mean, we don't really know, right? Like, there
Nope,
is
nobody
100 years later, we have no fucking clue of how like millions
right.
actually work, right?
But like you can't
It's
ask anybody about partition coefficients because they'll start to panic and like they don't know what Meyer Overton is. And I'm a big believer, like you shouldn't be, using stuff with false confidence when you genuinely don't understand what you're doing, especially when what you're doing holds a life in the balance. But, that's just my soapbox anesthesia spiel. But yeah. Yeah, like I
no,
mean, I'll say
totally.
that I'll get people all the time like, "Well, I want to learn ultrasound guided blocks," and I'm like, "Well, what's the mechanism of action of propofol?" And then they won't know, and then I'll be like, "Well, I guess we are going to learn how to walk before we fly today, aren't we?" Yeah,
Absolutely. Yeah. That's nuts.
which we could
Um,
not be more far off of like volume resuscitation right
True.
now if we
True.
tried.
look,
I guess
it's
I guess that's also the thing that influences so much of what I do is like I am very lucky. Like I argued when I first started, like we need gas analysis in every monitor that we have, and I've got it in like over 50% of the monitors. Every surgical monitor has gas analysis. So I know inspired expired ISO. So like I can walk in a room and know essentially where that patient's at with like a glance at the monitor and then like knowing the protocol in my head. So if I walk in and the dog's at 1.7 and this is a patient that also got dexmedetomidine and methadone, I'm like, all right, like I will walk over and I will immediately adjust the vaporizer and be like, all right, we're gonna have a discussion on how this is like a completely inappropriate amount of drugs to be giving this patient because it is. And like if I walk in and the patient's, 0.6 and we haven't cut the patient and we're in the midst of a fluid bolus, I'm like, well, this doesn't look like it's going great yet. So like let's start bringing in something else. Like let's, step out of the room, get a quick Mac reducer if it's a dog. If it's a cat, get a presser.
Let's grab that norepinephrine.
Yeah, exactly.
That's awesome. That's awesome. No, but that's the sad truth, right? Like, people see the pricing on, the gas analysis, and then it's like, I mean, I think we recently got some quotes. I mean, we just bought 8 new machines, um, and we got gas analysis, thank God, on all of them. But the price of the gas analyzer was almost the price of the monitor.
Oh
So,
yeah, yeah.
Well, it's funny because like a GP will have one multi-parameter monitor and they won't invest in that, even though let's say they'll do 5 to 6 anesthesias a day, but they'll invest in the $30,000 like digital x-rays for dental that they do, twice a day. And you're like, what's not going to kill you? A dental x-ray. What's going to kill you is an isoflurane overdose, especially where I get phone calls all the time in GPs like, my patient's profoundly bradycardic, like he's not responding, he's super hypothermic. And I'm like, okay, well, what's your ISO at? And they're like, 5. And you're like, oh, yeah, I think I've identified the problem.
11.
And that's not even in Celsius.
Which then, even worse is when you use the worst system in the world, the bane. The bane of my existence.
I know you feel, Ryan.
I feel like you should pay us for that joke.
I hate non-rebreathers. So dangerous. And then add lack of gas analysis to, I mean, I guess like with non-rebreather, you can argue, the concentration the patient's getting, but like, man, that is just such a rodeo. It is like playing with a loaded gun to me. Like, you just don't know, like, you're just adjusting that thing, and it's just all the patient's all over the place. The
It's a
depth
roller
is all
coaster.
over the place. No, thank you.
Yeah. I mean, we still teach the students, I don't, but some people still teaches the students that, above 7 kilograms, you can use your rebreather system, and below 7 kigs.
Made up number.
Yeah,
like,
that was back when the discs were made out of metal.
Like, where
right.
5 kilos, 7 kilos, 10 kilos? These are all arbitrary cuts. Everyone listening, all 3 people listening to this podcast, I just want you to know that all of these numbers.
So it's only 2.
Yeah, I was like, all of those are arbitrary cutoffs, and you could actually put a hippopotamus on a bane. You just have to have the right flow rate.
It's true. It's true. But you can also put your 2-kig cat on a rebreathing system. Just use the pediatric one, adjust your, bag size accordingly, and that's fine. It's totally fine. Nowadays, the valves are made of like super thin plastic. They barely have any weight. Every single time I keep unscrewing those valves and just showing them to the students, I was like, feel this. This is like,
well,
it's weightless.
I always get the answer for if you want to convert a small patient to a circle is that, and this is the hill that I'm going to die on. The bane might be your bane, Bailey, but mine is, well, when you want to put something small on a circle and they say, won't it be too much dead space? And I'm just like, what?
Dying
and then inside. I launch into, like, Bailey may launch into his isoflurane overdose thing, but I launch into my, do you know what dead space is?
Oh my God. Meanwhile, the tube is this far out of the patient. It's like a 5 that's never been cut. And they're like, but won't it be too much dead space? And you're like, not.
And I'm like, oh my God, that's the hill I'm going to die on, is the dead space and the circle argument. And I'm just like, I don't know what to do with everybody.
Oh, Jesus.
Some days.
Also, like, we have monitoring. Like, let's use our brains. Like, oh, look, the inspired CO2 is elevated on my circle on this 0.5 kilo animal. Wrong choice, Bailey. Move along.
I do think, though, that breathing circuits are one of the most, especially the non-rebreathers, are one of the most poorly understood aspects of veterinary anesthesia.
Oh,
especially if you point out things like people don't know that there's subclassifications of the non-rebreathers, right? Like they think it's a bane because they use a bane. They think it's like a T-piece if they use a T-piece, but they don't know about like A's and like I'll say you use a C all the time. It's an ambu bag and it's like, and you're just like, you guys, again, like we're using stuff that, can giveth life and it can taketh life right as quickly, and we don't know what we're doing.
Yeah. Yeah, no, absolutely. Absolutely.
So
Yeah.
fluid. So fluid.
We don't know
I
about
don't know
breathing.
how we ended up
We don't know
on.
about fluids. We don't know about isoflurane. We're really getting through the list here, boys.
Can't wait for
Yeah,
episode 2.
I don't know how we got to the vein system and now from fluids, but yeah, that's
It was the
jeez.
bane of Bailey's life, and then somehow I got on Dead Space, which just makes me want to give up.
Oh, jeez. I think that that's one of the most like poorly understood part of like, what actually is that space. And also like people worry about it randomly, right? Like I'm like, oh, but what about that space? I was like, well, their blood pressure is like 45, right? And I'm like, who the fuck cares of the dead space? You know
My
what I
favorite
mean?
is when the temperature is like 32.3, and you're just like, what are we doing here, people?
And that's in Celsius. It's not in
Oh my God.
That is in
Fahrenheit.
Celsius. It would be worse if it were Fahrenheit. But yeah, no, you're right. You're right, Beanie. Like we're worried about this much dead space, which most patients with normal physiological parameters who aren't at an inappropriate anesthetic depth will naturally overcome. But meanwhile, yeah, we're profoundly hypothermic, bradycardic, and hypotensive, and
Doesn't matter.
we're gonna do a dental.
Jeez.
Lord.
The other part is like that. I mean, if you put them on a ventilator, it doesn't fucking matter, right? Like,
No.
you can put,
Once again, it's like we have the tool right there to just solve all the problems. And again, human beings, you're probably going on the ventilator because you're getting paralyzed.
Because they paralyze everything in people.
I'm not saying they don't, but like they're using the vent all the time and they still have good outcomes
absolutely.
than people who smoke and drink and do all these bad things to our lungs versus these pets whose like lungs are like semi indestructible, honestly.
I mean, speak for your own cat. Mine's a total chain smoker.
It's
No, that's
so
fair. That's
awesome.
fair. I mean, I think I always get a little upregulated about positive pressure ventilation and like, is it causing biotrauma and like shear forces and
And
it's
hypotension.
physiologically an abnormal state. But of
Oh,
course,
for sure.
like,
For
is it
sure.
going to make a big deal in a 20-minute spay?
No,
It's
it
probably going to make
doesn't.
a big.
It
More sense
doesn't
with
matter.
the vent than
Yeah,
like
it's probably
actually.
going to make a. I mean, I don't vent from the get-go on every case.
Yeah, for sure. Oh, I
Uh,
barely vent at all. Like it's out of laziness, honestly.
Well, I barely vent at all because I try to, keep isoflurane at an expired fraction of basically like 0.8. That's my goal.
Yep.
I'm like,
Yep.
let's get this bad boy down below 1. Let's do this, people.
Jeez. I mean, to be honest, though, right? If more people were to understand like how actually to use a ventilator, it would make their life much easier, right? There is a lot of like practitioners out there that are really worried about it, right? And actually, if you know how to use the tool, it makes your life so much easier, right? How many patients suffer complications because they don't breathe for them, right? They forget about it, or while they're scrubbing, they're busy doing other stuff, and then the patient is apneic, and it becomes hypoxemic, right? Or how many patients actually do wake up because they don't breathe for them at the beginning of anesthesia,
No,
right?
people forget that, like, when the patient is apneic, likely from induction of anesthesia, that no breathy, no isoflurane, no anesthesia, right? So it's like,
Right.
they'll be like, well, I don't need to turn up the ISO or I don't need to intervene because the patient's not breathing, which means it's too deep. And it's like, no, that's not the same thing. Like, you can be just apneic and not be at an appropriate plane. But if you're not actually ventilating, you're not getting any uptake. Same thing in recovery. You're not getting any like egress of the inhalant. And it's like, obviously it's going to wake up, or obviously it's not going to wake up because you need to move the isoflurane. So, yeah.
Yeah, I think there is a lack of understanding on like how actually, again, the whole isoflurane thing or inhalants work, right? Like, you can turn up the vaporizer, fill up your circuit, but if the patient doesn't breathe, it's not going to take it in. right? So
I mean, I don't blame them, right? Like if you think about like even now vet school, you get 2 weeks on anesthesia if you're lucky, which is really
yeah,
10 business days, and you're supposed to learn everything that we know from like 3 or more years in 10 business days. And then you get out into a system where you don't have the supplies and you're limited in your drug usage. And so yeah, I
yeah,
do get it. I get it.
Yeah.
But at the same time, I'm like, it's okay to try to be better. And
And
there's
yeah,
the physics of circle systems are like they're not easy to understand. Like the physics of gas anesthesia uptake is not it is not simple. Like it's not simple at all.
Which
right. No,
brings me
that's true.
back to our oral exam, which was one of my questions was like the difference between the vaporizer and the end tidal, right? And so basically, like my end expired isoflurane value was higher than what the vaporizer was dialed, higher, and so you had to talk through how to troubleshoot that. That was my whole oral question, and I was like, oh, just gonna swallow glass, like just what a nightmare that was. But yeah, no, like I mean, it's not easy, like gas analysis, uptake, and all that kind of stuff. And you have to like, I had to be like, are we at high altitude? Are we at low altitude? Like, like it's
Is
ridiculous.
the vaporizer filled?
Before I asked that, yeah, was it filled with the right agent? Like
Yeah.
all. But yeah, no,
Is
that
it
was my
breathing methane?
back to the oral exam. It was totally about gas uptake, and do I understand how gas analysis works? And it was a real nightmare of a question.
Oy.
Mm,
Yeah, I wouldn't have wondered that question. Definitely, you
yeah.
know.
No, I definitely sweat in some uncomfortable places, gentlemen.
Awesome, awesome. So I think to recap it for everybody, fluid bolus is fine if your patient is dehydrated. Otherwise, I mean, it's probably one of the least um,
Effective?
dangerous options that you have, and
Sorry.
also probably the least effective of your options. It's 100% true.
Do you feel like
Yeah.
cats are lower likely? Like I personally, just like subjectively, and I have no evidence to back this up. So like this is all just wild speculation from
This is
me.
my favorite kind from you, Bailey. It's when
Do
there's no
you?
evidence whatsoever and it's your wild speculation. So lay it on
No,
us.
no. It's not just I've been doing this.
Is
I've been
this your
doing it.
sympathetic thing about cats? The
No,
cats
no. This is not going there. Not yet. I mean, I've been doing anesthesia for 10 years now. It's wild.
You're so
But
old.
I know. Do you think that cats are less likely to respond to fluid boluses than dogs?
Ooh. Hmm.
Right.
I
See,
don't.
I feel like dogs are responders and cats are just not.
I don't know, man. I mean,
Now, here's a question. Let's put it into some context. Do you think it's because your fluid resuscitation protocols are more judicious in cats? So, do you give less volume and more slowly? Because if you're really, because like you can hammer fluids into a Labrador,
It
and
is fast for me always. Like
right?
it is as fast as the pump will let me go. Is as fast as gravity allows it to drip through the catheter. It is
Okay,
as
okay,
fast as
okay.
I can push a
Because some,
syringe and
because some people really, they're like, oh, I'll give 2 mils per kg over the next 5 years, and you're like, well, why bother? But I just didn't know if you maybe your fluid approach to cats was more judicious, so it was inherently biasing you. But that's fine.
for sure. The volume is lower. Like I do give cats a 5 ml per kilo bolus based on like the idea that cat's blood volume is 60 relative to a dog's blood volume of 90. So I do give them less. So like yes, that is an interesting point. Like to me, giving 20 mils per kilo to a cat seems like
And has anyone ever studied to see whether or not a cat actually has a proper Bainbridge reflex like pigs and people and dogs and non-human primates do? Because I don't think they have. So maybe they don't have that kick up for like atrial stretch does not initiate a tachycardic reflex.
yeah.
yeah, that's fair.
This
Fair
is
point.
my wild speculation in response to your wild speculation, which brings me back to the whole theme of fancy. But anyway, yeah, no, I mean, let me put it this way: there's not a lot that cats respond to.
No.
My general go to for a cat is ephedrine.
Yeah. Diminishing
Wow.
returns though.
Yeah, I like ephedrine in a cat. It's I find it more predictable. I get good duration. I don't tend to get like crazy tachyarrhythmias with it. I don't have to set up a
Interesting.
CRI, which is great because I'm inherently lazy. So that's super, but yeah.
What dose of ephedrine do you normally use?
Zero point 0.1 mgs per kg,
Okay.
How
Okay.
often
I,
about every 30 minutes.
and how many times?
Well, until it stops working, until you hit the wall of tachyphylaxis.
Right, that's what I was wondering. Like
But
how
I've never
long?
hit it, right? Like I've never, because I'm not just sitting there. Let me be clear to our 3 listeners. I'm not just sitting there doing nothing but slamming in ephedrine.
No, typically I've not used ephedrine because like we don't have it where I work. I have seen it used in some practices, but just don't
It's not
have
as
the
great in dogs. It maybe buys you 5 minutes of a burst in a dog, and then it just
yeah.
wanes. But I've never hit the tachyphylactic ceiling in my patients because I'm doing other things like trying to turn my ISO down and titrating CRIs and warming them up and telling the surgeon to hurry up and stop talking with your hands in the air and put them back in the abdomen type thing. So yeah, I have never hit that tachyphylactic, but I did once allow a technician who was doing VTS training to run an ephedrine CRI. And I think we probably were,
wild.
yeah, yeah. It's doable, but you just can't do it for hours and hours. So we had it on for maybe like 40 minutes and it was efficacious. But I think if we'd pushed it much past that, but again, I have no idea because fancy guessing, like I don't know what your endogenous levels of noradrenaline are. So, and I don't know how much got used putting the catheter in. So it's impossible to say. But yeah, ephedrine's my go-to in cats.
Hmm.
Just mix it
Wow.
up, mix it
Okay.
up, mix it up,
It's,
Beanie and Bailey.
I mean, it's kind of hard to get ephedrine in the States, like depending on, which state you're in, but like almost every state is trying to crack down on, the use of ephedrine around.
Really?
Well, yeah,
I
you
mean,
can.
I get why, but yeah, like because I have no problems getting it up here in the wilds of Canada.
Yeah. Like every single time you go get Sudafed, which is like pseudoephedrine, you need to give them your driver license and the stuff, right? So like, think about having the injectable version, which is even more pure. It's like,
Whereas up here in Canada, like you can just buy it over the counter. Meanwhile, I'm not even, and I'm not going to make the gun control joke.
I mean, at least you have Kinder eggs, right?
But yeah, sorry, I didn't realize there was an issue with availability. But yeah,
Yeah, it's
yeah,
hard to
are
come by.
cats less fluid responsive? Bailey, I've never really identified that pattern, but I've also not been looking for it. But now that you've said it, I'm going to
Yeah,
spend like the next 3 weeks just staring at every cat.
I mean, I'm a
me too.
like I am a like most of my patients, I would say 90% of my patients, if they are hypotensive and I think we've already turned down the gas, like step one is going to be some amount of fluids to see if they respond, to like gauge their response with the idea of like maximizing the diastolic filling as best I can because we don't have ways to measure it easily in my patients. And I believe most of my patients are going to fall in that like nice part of the bell curve where I'm not going to overload them and I'm making very conscious decisions about these patients because I, have a population where I can really monitor them closely. And so like I feel I don't see cats respond as quickly. And dogs, I feel like I get a lot of response.
Okay,
That's fair.
Cats
interesting.
I'll
really jealous.
keep an eye out for it for sure now.
Do you guys always check before you start like intervening with fluid therapy? Do you look though for like pulse pressure variations? Because what I sometimes do is like I'll just bag the patient if I'm not ventilating them, right? I'll give them a few positive pressure breaths and then I'll see if I get a big response and then
I mean,
maybe make the
knowing
decision
how
to use volume.
knowing how subjective that is, and then with the like kind of lower crystalloid rates we run them at in modern anesthesia, I feel pretty comfortable giving them like at least one bolus before I decide to like alternate other
Well,
therapies
yeah,
with
yeah,
it.
yeah. No, I won't check it before one bolus, but let's say, we're climbing up to we're still tachycardic and hypotensive.
For sure.
And then I'll be like, you know what, let's just see if there's really volume deplete. And then also I'm monitoring to see whether or not you're responding. Because if you're not responding, even though you're deplete, I'm just going to stop and put you on a vasoconstrictor, right?
Right, exactly. Like that's exactly the point is like if you're not responding, why do you go back to that same well? Like you've already exhausted that.
I
Like
think
you've
it's
done,
because people don't realize that there is like a responder's curve,
yeah,
right?
for sure.
I don't think that is not something that is I think, taught at vet school. I think
Absolutely not.
They're on the they're already on the flat part of the Starling curve,
I was about
Like
to say,
some
here
days,
we are again at Starling. Like,
yeah,
There you
here we
go.
are again at Starling. But yeah, no, I think just because you are hypovolemic does not mean you are going to normalize blood pressure with volume resuscitation. And
Yeah.
and I don't think that's something that is well known within the general community. So
Yeah.
I
No,
think some
that's fair.
anesthesiologists don't know that.
Probably. That's probably true. I actually, coming back to your point of like tachycardia, and so if my patient is not tachycardic, I usually look at PCVTP, and if it's not abnormal, then I skip the fluid bolus entirely, completely. Like I don't even give one, period, zero. Um, if you, again, going back to the not wasting time on stuff that doesn't work. Um, and then, I mean, if that's not the issue, that's not the issue, period. Like, right, you know what I mean? But if it is tachycardic, um, I usually actually do a mini fluid challenge. You know, I just give 3 ml per kg real fast, slam it in, and look for that drop in heart rate, right? And if it does drop like 10 points or more, then there you go. That's a fluid responsive patient. Um, but but yeah, I guess I never. Yeah, I mean, I look at pulse pressure variation if it's a rate on a ventilator. I guess I don't know, out of laziness, probably I never actually did beg a patient to trying to trigger pulse pressure variation. Um, but yeah, I'll start doing that more actually. That's pretty cool.
So what are your guys' thoughts on like this concept of the relative hypovolemia that we may or may not induce from like iatrogenic vasodilation? So layman's terms, like we put them on vasodilators and then the volume becomes relatively hypovolemic to the actual volume of the vascular tree. That theory used to be really common, but it's kind of on the fence now as to whether or not it has merit.
I mean,
Yeah, sorry, go for it.
oh no, you go.
No, you go.
Okay. I mean, I definitely am going to be in the camp that's like you in your normal healthy patients who are not dealing with like multiple comorbidities or significant underlying disease that's requiring surgery.
Okay. Because it used to be like the thing was like you wanted to fill up the well, right? So like you expanded vascular volume, you wanted to fill up the well with the volume deficit to stabilize blood pressure. But
Yeah,
yeah, okay, Beanie.
yeah. No, that's to be honest with you. If the issue is vasodilation, fix the vasodilation, right? Like give Norebi. If that's your worry, like the vasodilation and the decrease in contractility from the ISO, norepinephrine is your key. Now, if the issue is heart rate, give an anticholinergic. If your issue is dehydration, give fluids. If your issue is the patient is too deep, then make it lighter. But if those three are not the problem, then norepinephrine is your answer in probably 95% of the patients, bearing mitral valve disease or
He
DCM.
just made anesthesia sound so easy, eh? Like he's just like, yeah, just do this, just do this.
No, I mean it's not, but like it's
No, I think the
I
issue is like which one is it, and then relative degrees of it. Like maybe it's 5% dehydration and 19% hypothermia and whatever percent. And the thing is that we're used to it, so it's like yeah. But in GP, they're like, I don't know if this patient is hypovolemic, or I don't know if this patient is and they get in a fluster because it's multifactorial. But you did make that sound really easy. Like, oh, if it's hypovolemic, give it volume. If its heart rate is low, give an anticholinergic. Like, oh.
no, it's not. It's not. But um, I don't know. I think that's how I think in my head. But yeah, of course, there's different shades of hypotension, I guess. Um,
Yeah. And there's some
Anyway,
days where you're like the textbook reads, like you'll see like maybe lactate is 5.6 and basic stress is -11 and the patient has weak peripheral pulses and it's, PCV is 61, like all the signs are there. Like its pulse pressure variation is 17%, and, like you said, and you follow the textbook, right? Like you normalize heart rate and you lower the ISO and you give, a pressor and a bolus and they still stay hypotensive, right? And you're like, why is this
yeah,
happening? It's never in the patient that you expect it in too, right? Like it'll be in some 2-year-old TPLO lab and you'll spend the whole anesthesia battling this dog from the brink of death for no apparent reason, and meanwhile, like the 18-year-old cat getting its O tube because it's in renal failure just like cruises the anesthesia like nobody's business. And you're like, I'm definitely losing at the game today.
there's always going to be the exception out there. You
Oh
know what I
God.
mean? You always, oh, you're fine. I can cut that off. You're good.
I was like, wow, I'm deaf.
So I am.
I was like, oh, I must have been the
I'll be
corny.
sending you the bill for the hearing aid. Um,
Hilarious.
geez. All right, I think we're coming up on the hour. Thank you so much for being here. Thank you so much for all your answers and extra questions that now we have. Um, and I guess we'll see you in the next episode.
Yeah, I
Uh,
can't wait. I can't wait to decide what we're gonna catastrophize next time.
who wants to pick the next topic? Ryan or Tasha?
I think we should go alphabetically, and Bailey comes before Bartel.
Okay,
But I'm
that's
happy to
fair.
give today's summary, which is we don't understand fluids, and we don't understand isoflurane, and we don't understand cats, and yeah, we don't understand circuits, and we're the experts. So that's super comforting.
Yay!
I hope Peter Pasco never listens to this. He'll just be so mortified that he trained any of us. Like he'll just be like, those three just need to get voted off the island.
At some point, your phone's gonna ring, and Peter's gonna be on the other side of the
Oh
line.
God, it's gonna be P3P, and like I'm just gonna. Oh, the sweating is gonna start again.
I may or may not shoot him a link.
Don't you dare! Don't you dare! Don't you dare! No, this link only goes to very specific anesthesiologists.
Oh well. Oopsie, oopsie, poopsie.